So the last subject we're going to talk about in pathology is mental health disorders. And even though in physical therapy we are not, strictly speaking, treating people for mental health disorders, we are often doing physical treatment on people who do have mental health disorders. And so, I don't know, there's some days when I feel like a psychologist or psychiatrist, but clearly I'm not. And but we are going to run into these things, and it's good to know a little bit about it. So, mental health disorders, they're classified in the Diagnostic and Statistical Manual of Mental Disorders. 5th edition is the current edition that's out. It's known as the DSM-5. So, if you want to know if something is officially classified as a mental health disorder, that's where you look. So, when they do new editions, a lot of times they add or subtract things. The latest edition has some interesting additions, such as bipolar as a result of amphetamine abuse, bipolar as a result of other drug abuses. So sometimes when they add new things, it's because more of that is being seen in the mental health treatment setting. So mental health disorders are defined as dysfunctions in the areas of behavior or personality. So clearly it's not a physical dysfunction such as we're treating in physical therapy, but there are often biochemical or structural abnormalities that may be identified associated with the mental health disorders. There's often a genetic component. Psychotic illnesses include schizophrenia, delusional disorders, mood disorders, anxiety disorders, and panic disorders. What we're going to talk about is types of disorders. I'm going to try to split it up into 2 lectures just so you don't have to listen for an hour, because there's a lot of information here. Anxiety disorders, somatiform disorders, or factitious disorders, and mood disorders. We're going to talk about these in the first section, and then in the second section we're going to talk about schizophrenia, cognitive disorders, and eating disorders. So anxiety disorders, they are defined, or they present as feelings of fear and apprehension that are out of proportion to the situation. The cognitive presentation is worry or panic, or reacting to misfortune with a feeling of impending doom. So obviously all of us have anxiety, at one time or another, and so the thing that makes it a disorder, just rather than just being regular anxiety, is if it's negatively affecting your life, it's making it difficult for you to function in your normal activities, in your work or your home life. So anxiety itself isn't a disorder, but an anxiety disorder is anxiety that is out of proportion to the situation or making it difficult for you to function. So the behavioral presentation of anxiety disorders is avoidance of the thing that causes you anxiety. So biogenic causes have been found to be dysfunction in the locus ceruleus, which is underneath the cerebellum. It's the center of the anxiety system in our brain. You can have anxiety reactions with stimulation of thoughts or anxiogenic substances such as caffeine or stimulants like cocaine. Antidepressants have been found to raise the threshold of the anxiety system, which means you can tolerate more without going over into that anxiety reaction. So a lot of times antidepressants are used in the treatment of anxiety disorders as well. So there are lots of different classifications of anxiety disorders. Panic disorders, generalized anxiety disorder, or GAD, Obsessive-Compulsive disorder is an anxiety disorder, and post-traumatic stress disorder is an anxiety disorder. The pharmacology that's usually used for treating all of these things includes antidepressants and anti-anxiety drugs like Xanax and Ativan. Usually antidepressants are, when they're prescribed, they have to build up to a therapeutic level in your system. So usually when someone's on antidepressants, whether they're using it to treat depression or anxiety, they are on it continuously over a period of time. Anti-anxiety drugs, on the other hand, are usually used on an as-needed basis. So they are not necessarily, you're not on a regular dosage of them, you just take them as you need them. So panic disorders are classified as severe and frightening episodes of apprehension and feelings of impending doom. The physiological responses that go along with panic disorders include sweating, a feeling of choking, heart palpitations. Usually when somebody has a panic disorder, sometimes people feel like they are having a heart attack because of the heart palpitations and the sweating and choking. Those could be associated with heart attack as well. Usually the physiological responses of a panic disorder only go on about 3 to 5 minutes. It just feels like forever, I guess, when it happens. So a lot of times when people are going through psychotherapy to deal with panic disorder, part of it is getting a hold on that idea that even though they feel that panic, it's not going to last forever. There has been a genetic factor implicated, which shows an increased discharge of neurons in the temporal lobes, and some neurotransmitter abnormalities, including norepinephrine, serotonin, and GABA. So obviously your neurotransmitters are doing a lot to control the nervous system, and so if there are abnormalities in neurotransmitter function or distribution, you can have a physiological response to it. Generalized anxiety disorder versus panic attacks. Panic attacks, it's anxiety at certain times. Generalized anxiety disorder has persistent high levels of anxiety and excessive worry over many life circumstances. It also has the physiological response: palpitations, muscle tension, restlessness, poor sleep, and poor concentration. Obsessive-compulsive disorder, so it can include obsessions and compulsions, which are two different things. Obsessions are intrusive or repetitive thoughts or images that produce anxiety. Compulsions it's the need to perform acts or thoughts to reduce anxiety. So the obsessions and compulsions can occur together or separately, and there's no conscious control over the thoughts or acts. There's increased anxiety if the person attempts to prevent or stifle their thoughts or acts. So you have the physiological responses to that anxiety is the same as with general anxiety disorder, but the performing the acts, whether it's hand washing or moving things a certain way or doing movements in a certain pattern, that sort of thing, help control the person's anxiety, or it causes anxiety if they can't perform those acts. Post-traumatic stress disorder, it's an anxiety disorder that's developed in response to extreme psychological or physical trauma. So the trauma can be to the person themselves, it can be to someone that's close to them, or generalized, like people who are in the military, in war zones, or not in the military, in war zones. A lot of times it's general post-traumatic stress disorder. It might not be something that happened to them or someone they were close to, but it's something that happened to people around them. The physiological responses are similar to general anxiety disorder, and often post-traumatic stress disorder includes depression. So I've worked with several people with post-traumatic stress disorder, either retired military people or people that had trauma or something that happened to them, and it can be a very debilitating disorder. So one time I was working with a guy. He was a veteran of Vietnam War, and he had post-traumatic stress disorder. For a lot of his life after he came back from Vietnam, he was able to keep it under control with medications. He was able to function normally. Actually, he's a very high-functioning individual. Had a high-level job and had a family and everything. After many years, he started to undergo chronic renal failure and could no longer take the medications to control the post-traumatic stress disorder, and it was devastating to his life. He basically couldn't deal with his family anymore and couldn't deal with his job anymore, and it changed his life in a really negative way. Sometimes people with post-traumatic stress disorder can have a panic-like attack. One time I was working with him in the gym in our clinic, and he started having a panic attack, basically, or post-traumatic stress disorder attack. And so I couldn't just make him leave. I had to deal with it. So I had him lie down, put his feet up. I coached him through some breathing exercises. I listened to him while he was talking. We basically ran out of time this session, and my next patient was there, but luckily one of my coworkers was available to treat my next patient, and I stayed with the guy until he got through his attack. And it was interesting, and it was difficult to deal with. They could put you. It's a difficult situation, so it could happen definitely in a physical therapy setting. And I've also had someone have a PTSD attack while we were doing manual therapy in a treatment room, and the reaction was just about the same as get them in a comfortable position and talk them through some breathing exercises and help them get through it, basically. The interesting thing when with the patient in the manual therapy setting, I had a student with me at the time, and she was giving me some looks, let me tell you. But it was a really good experience for her because she got the experience of dealing with that. So somatiform or factitious disorders, they're complaints of physical symptoms that closely mimic authentic medical conditions, but there's no physiological basis for their complaints. It's not, the person's not faking it. The symptoms are not under their voluntary or conscious control. It's just whatever psychological thing that's going on is manifesting as a physical symptom for them. So the types of these disorders: somatization disorders, conversion disorder, which is a specific form of a somatization disorder, and hypochondriasis. So with somatization disorders, the person has chronic complaints of physical symptoms without a physiological basis. So in order to be classified as a somatization disorder, they have to have a history of complaints with at least 4 pain symptoms in different sites, 2 gastrointestinal symptoms, 1 sexual dysfunction symptom, and 1 pseudo-neurologic symptom. So numbness and tingling, paresis or paralysis, that type of thing, pseudo-neurologic symptom. So people with somatization disorders, of course, it's difficult to get it diagnosed because even though they have physical symptoms that they can't control, a doctor can't find a physiological basis for it. So those people often shop around for medical caregivers because they go to one doctor and the doctor says, well, there's nothing wrong with you, or I can't find anything wrong with you. And so they say, well, I'm going to another doctor. And so a lot of times they'll go from doctor to doctor to try to get someone to diagnose. And hopefully, eventually they run across a savvy doctor who knows about this and gets them the right care that they need. But unfortunately, they often have frequent or multiple surgical procedures because they're trying to fix something that's not there. And they're going to shop around until they find a doctor that will do a procedure on them. And unfortunately, that happens. Sort of a specific area of somatization disorder is conversion disorder. which is where the person has neurological symptoms without organic cause. So it can be paralysis, like complete paralysis, where they can't walk. Anesthesia, where they can't feel things. Paresthesia, where they have unusual sensation, loss of hearing or sight, or dizziness. They could also have a neurological effect. I worked with a woman one time with conversion disorder, and the neurological effect that she had was narcolepsy. Narcolepsy is where you fall asleep suddenly for no reason. And she ended up in the skilled nursing facility where I worked because she fell asleep while she was driving and crashed her car into an embankment and had bilateral tibial fractures. So very interesting to work with. I've worked with several people with conversion disorder with paralysis or difficulty walking being their main symptom. So a lot of times they're being worked up. They're looking for possibly MS or some other, like a spinal cord injury, something that is going to cause them to lose their ability to walk. But the more tests that are done, the more that they see there's no organic cause. It's usually treated with psychological therapy. However, physical therapy is often an adjunct for that conversion disorder. And the way I see it, our role in physical therapy is to make sure the person is still moving as much as possible to counteract the effects of immobility. So whether their paralysis is organic or psychological, they're still not moving and they still have the effects of immobility. So they're going to get muscle atrophy, they're going to get dysfunction of the muscles from not using them. And so I've actually worked with a lot of people who successfully got through conversion disorder, and it's really interesting. So a lot of times we're working on simple exercise programs that they can do at home, either by themselves or with the help of a caregiver. We're working on standing and walking tolerance. I've done aquatic therapy with several people with conversion disorder. Basically working on functional mobility, and at the same time that the person is getting their psychological therapy. And I've seen people have really good results. And then I've worked with some people who, because they were shopping around physicians, they end up moving out of state or moving to another region because they were looking for something else, in their doctors. And so I never found out what happened to them. But it is a really interesting thing to work with, and the temptation is to say, oh, the person's just faking it, and they're not faking it. They do not have conscious control of their symptoms. They are, as far as they're concerned, they can't move their legs or do whatever function that they that is affected on them. So it can be very debilitating, very interesting disorder, and frequently referred to physical therapy. Hypochondriasis is persistent preoccupation with health and physical condition, even in the absence of organic problems. Fear of disease, illness, or death. The tendency to self-observe, and hypersensitivity to bodily functions. So people go, oh my gosh, I have a fever or something. Maybe they don't. I don't know. Maybe they do. But they, looking up things on the internet, trying to diagnose themselves with different things. And it can be very difficult for doctors to treat because they can't find anything wrong. There's nothing to treat. So a lot of times it is treated as a psychotherapy type treatment. Mood disorders are disturbances in emotions that cause subjective discomfort and or impair a person's ability to function. So they have a tendency to run in families, so there's probably a genetic component. There is a biogenic cause for mood disorders. A lot of times it has to do with neurotransmitters, norepinephrine and serotonin. If there's too much activity with these neurotransmitters at the synapses, it can cause mania. We'll talk about mania. And if there's too little activity at the synapses, it can cause depression. So a lot of the antidepressant drugs like Zoloft and Prozac are selective serotonin reuptake inhibitors. So what normally happens is the serotonin the synapse is released by one neuron, floats across the synapse, and it binds to receptors on the next neuron. And then any serotonin that's left in the synaptic cleft is reuptaken by the secreting neuron, while the reuptake inhibitors keep the serotonin in the synapse longer, and so it can have more effect. So, and then with mania, there's too much effect, so they want to have an inhibiting effect on the serotonin. So the two types of mood disorders that we're going to classify are depression and bipolar disorders. A lot of times, the factors that contribute to these disorders can include genetic, developmental, and psychosocial stressors. So depression, the affective presentation is sadness, dejection, prolonged mourning, feelings of worthlessness, and a loss in the joy of living. And the name for that is anhedonia. The cognitive presentation is pessimism, disinterest. So they're disinterested even in things that they used to be very interested in. They don't have any interest in them anymore. Decreased energy, loss of motivation, self-denigration, and low speech volume. With bipolar disorders used to be called manic depressive disorders because people would cycle between mania and depression. They've now split it into 3 different types of bipolar disorders. The first one is bipolar 1, and it's classified by 1 or more manic episodes. So with bipolar 1, people cycle between sort of a normal affect and a manic. So they cycle between normal and manic. The affective presentation of mania is elation or irritability, grandiosity, exaggeration, verbal or sexual inhibition, impulsivity, decreased sleep, and the feeling of boundless energy. So they're bouncing off the walls when they're in a manic episode. The cognitive presentation is accelerated and pressured speech, tangential content, so they're bouncing all over the place with topics, and disjointed thoughts in speech. I worked with a guy several years ago who had bipolar 1, and he was like a very nice guy, except when he was in a manic phase, he was really hard to deal with. Because of that disjointed thoughts and speech and tangential thing, it was really hard to keep him on task. He was coming to physical therapy after a back surgery to recover from the back surgery, and he would come in to the lobby and he would yell at the people at the front desk, and then he'd get on the lobby phone and he'd call his doctor's office and he would yell at them, and he would, and then he would come back, and he was pretty nice to me, but he was a little bit difficult to deal with because he was so, he'd be very loud, that verbally uninhibited thing. A lot of times people, especially when they're in a manic phase, with bipolar, they do not like to be in an enclosed room. They want to be in a bigger area. So someone who's really impulsive and uninhibited verbally, I don't necessarily want to take them into the gym with a bunch of other people, but if they're uncomfortable being in a closed area, I will take them into the gym. So interestingly enough, he told me his bipolar was, he's had success treating it with medication, but when he was in a manic phase, he told me that when he's in that manic phase, he feels like he's closer to God, so he's not motivated to take his medication, and then he just gets worse. So very difficult to deal with. He did have good physical recovery from his surgery, and met his physical therapy goals, but it was a real challenge working with him. So bipolar 2 is sort of the opposite, where instead of cycling between sort of a more normal affect and manic, it's cycling between a normal and depressive. So bipolar 1, they have one or more manic episodes. Bipolar 2, they have one or more depressive episodes. So normal, cycling between normal and depressive. Cyclothymia is what is generally considered to be like the classic bipolar disorder or manic depression, where people are cycling between depression and mania. Interestingly enough, one of my friends who's an ER nurse, she said when people come into the emergency room and they're in a manic phase, the first thing they do is try to calm them down out of that manic phase with medication. They use anti-mania medications. If someone comes in with a depressive episode, they're usually treating something else. They're not necessarily, because it takes longer to get someone with medication out of a depressive episode than it does to get them out of a manic episode. I thought that was really interesting in terms of medication. So the treatment for mood disorders are usually pharmacological, antidepressant, or anti-maniac drugs. Electroconvulsive therapy is also used, and since I've only seen it in movies, it seems scary, but you watch One Flew Over the Cuckoo's Nest or other movies, but it actually is a viable treatment that is still being used, and it's not scary like it is in the movies. Okay, so we're going to wrap this up, and then in the next section we're going to talk about schizophrenia.